Hi, everyone. Welcome. You should be able to see our screen with our Rare Disease Grand Rounds title. Hi, Bonnie. Thanks for turning on your camera. Hi, Jen. You are welcome to have your cameras on, but you can have them off as well. But during the Q&A, it'd be lovely to see everybody's faces. Welcome, everybody. Hi, Autumn. How are you? Hey, Jake.
I'm okay.
Okay, good. I see lots of faces I know, some I have yet to meet. So exciting. We're going to get started right away here as people, I guess I should wait till there are a lot coming. Okay, trying to give everybody time to enter here, but I don't want to start late, so we're going to get started. So welcome everyone. It's so nice to see so many folks I know and those I have yet to meet. Thank you so much for joining us today. I am so very thrilled to have the privilege to introduce the first NORD Rare Disease Centers of Excellence Rare Disease Day Grand Rounds, and we may need to think of a shorter name for next year. For those of you who don't know me, I am Mary Beth McAfee, Director of Medical Affairs at NORD. The main program I oversee is the NORD Rare Disease Centers of Excellence. I do want to give a huge shout out to Darby Gavin, who is managing the chat and you will meet during the Q&A, and to Anjali Chauhan, who can't be with us at this moment because she is also a full-time student in the Mount Sinai School of Medicine Genetic Counseling graduate program and is in class. This event was conceived by Darby, who is managing the NORD's Rare Disease Day initiatives, and pulled together by Darby and Anjali. Thank you both for turning this idea into a reality, and thank you to all our presenters today. I would like to start out sharing NORD's mission, which is to improve the health and well-being of people with rare diseases by driving advances in care, research, and policy. Couple housekeeping notes. This meeting is being recorded. Please mute your mics. If you are comfortable, you can turn on your video or your camera, especially during the Q&A at the end of the webinar. Please use the Q&A feature for directing questions to NORD or the panelists. Please use the chat for sharing resources and connecting with fellow participants. We will do our best to answer all questions during the webinar, but we'll follow up after the event with you if we did not get to your question. We will be following up with a recap and a recording link to the meeting to all registered participants, and we will be ending the meeting at 3 p.m. ET to be mindful of everyone's time. So what is Rare Disease Day? Rare Disease Day was created by Euroidis, Rare Diseases Europe, and was first launched in 2008 with the Council of National Alliances. The goal was to build a global awareness campaign to help bring rare diseases to the spotlight. February 29th, the rarest day, was chosen for the date. 2009 marked the first time Rare Disease Day was observed in the United States. NORD mobilized more than 200 patient organizations and continues to be the official U.S. sponsor of Rare Disease Day. Our Show Your Stripes campaign, as you'll see by all the zebras around me and my shirt, began about 6 years ago. Every year, NORD works together with our sister organization, Euroidis, and other national alliances to drive an international campaign that shines a light on rare diseases and advocates for health equity for all those living with a rare disease. Visit rarediseaseday.us to learn more and see how you can get involved in Rare Disease Day. About 3.5 years ago, NORD launched the NORD Rare Disease Center of Excellence program. Each NORD Rare Disease Center of Excellence has experts covering all medical specialties required for the diagnosis and treatment of a broad range of rare diseases for both children and adults, and has demonstrated a strong commitment to supporting all stages of rare disease research. In addition, each NORD Rare Disease Centers of Excellence is dedicated to mentoring the next generation of rare disease clinicians and researchers. There are 40 rare disease centers of excellence located in 26 states, plus the District of Columbia. Each rare disease center of excellence is made up of multiple institutions, and many have outreach clinics across their own state and beyond. We are working really hard to strengthen our network and to better serve rare disease patients and facilitate research collaborations, but we are still in many ways in our early days. Today's webinar is a chance for us to share just a small part of the amazing work that is already taking place at 3 of our rare disease centers of excellence. Sorry, just Dr. Hatem El-Shanti, who among many roles is the director of the University of Iowa Healthcare NORD Rare Disease Center of Excellence, passed on the honor of introducing our first presenter, Dr. Bharat Chandra, to me today. Dr. Chandra is a geneticist, and rare disease researcher at the University of Iowa. Dr. Chandra will share University of Iowa's experience from the Iowa Undiagnosed Diseases Program, highlighting the clinical landscape challenges and emerging approaches for individuals suffering from undiagnosed diseases.
Thank you, Mary Beth, for the kind introduction. Are you able to see my slides?
You're set.
Thank you. First of all, I would like to thank the organizers of NORD for the opportunity to speak at this grand round. It's really an honor and privilege. These are my disclosures. I have no financial disclosure to declare. For this program, some of the work was supported by industry partners who provided reagents, software, and bioinformatics support, and they had no influence on the enrollment, conduct of research, and the content of this talk. Today, I'll be talking about the journey of 2 patients with undiagnosed rare diseases from the University of Iowa Undiagnosed Diseases Program. I will also share the perspectives of their caregivers and also perspective of our UDP genetic counselor, Anna Paulson. This is Sutton, a couple of months ago, and I have his parents' permission to share his name, pictures, and clinical information. And this is Sutton now, and unfortunately, he has an undiagnosed rare disease. Sutton has a rare disease which by definition affects fewer than 200,000 people in the United States. We know that there are over 10,000 unique rare diseases affecting over 30 million people in the US and about 500 million people in the world. We also know that a majority of these rare diseases affect children with a strong predilection to involve the neurological system. In general, it takes about 3 to 15 years to establish an accurate diagnosis, although the time to molecular diagnosis is getting better thanks to rapid adoption of next-generation sequencing technologies in clinical practice. However, despite these advances, more than 50% of cases with suspected genetic disease, like Sutton's, remain undiagnosed. This resulting uncertainty is one of the major contributors of therapeutic odyssey associated with rare diseases. When we think of undiagnosed diseases, it can be grouped into these 4 clusters. The top left represents atypical manifestation of a common disease, which can masquerade a genetic disorder. An example will be diabetic amyotrophy, mimicking a genetic ALS. The top right represents a typical presentation of a rare disease, but it requires an expert who's familiar with that disorder to establish a diagnosis. The bottom left in blue represents atypical manifestation of a rare disease, and this can be perplexing to even seasoned rare diseases expert. And the box on the right is unknown rare disease. So these are undiagnosed diseases that are not discovered yet and hence do not exist in the literature. The Undiagnosed Diseases Program at the NIH has been a game changer in accelerating gene discoveries and is establishing accurate diagnosis in individuals with undiagnosed disease. Unfortunately, it is not possible for every patient with an undiagnosed disease to receive UDN level of care, especially if it requires traveling out of their home state. This unmet need motivated us to start an independent undiagnosed disease program here in Iowa, which was supported by a philanthropic funding. This model, as you can see, is very similar to the UDN model because we know that framework is well established and has good success rate. In this model, we essentially focus on three components, which is clinical deep phenotyping, research-based genome sequencing and research-based reanalysis of genomics data, research-based multiomics, and cell-based modeling, as well as small animal models. To make it possible, we needed a team of like-minded people who wanted to go the extra mile to help these patients. Fortunately, it was not that hard for us to find these champions. And a special mention to Dr. Nudge, who oversees short-read whole genome sequencing as well as bioinformatics for these patients, and Anna Paulson, who's a strong pillar for this program, and Dr. Calhoun and Dr. Safina, who have been referring, phenotyping these patients for the UDP. And Dr. Tung, who assists us with undiagnosed diseases, long read sequencing, and we are supported by expertise from Dr. Danny Miller. And Madeline Clemenson, she helps with functional assays, and Dr. Walker, based in Harvard, helps us with Drosophila-based models. Since we started this program, we have enrolled 66 individuals. And as you can see, majority of these patients have an underlying neurological disorder, not limited to neurodevelopmental disorder. It also comprises of ataxias and epileptic encephalopathies. And oftentimes, these are the hardest to diagnose. This chart over here shows how many of these individuals have completed a multiomics-based analysis. And as of now, we have identified either a candidate gene or a pathway that could potentially be a diagnosis in about 20% of the entire cohort. Back to Sutton's story. Sutton was healthy and had a normal neonatal course. At around 3 months of age, he presented with drowsiness after having a viral infection. This was followed by developmental regression, and around 4 months of age, he developed episodic spasms, which led to a brain MRI showing abnormal change in bilateral basal ganglia and brainstem. As a follow-up, he underwent exome sequencing, which returned with a maternally inherited POMGNT1 variant for a recessive disorder. So essentially, his exome sequencing was negative. He also underwent a mitochondrial DNA testing, which was also negative. His symptoms continued to progress, and he was admitted at 5 months for encephalopathy, apnea, and seizures. He was referred to the UDP team for further evaluation, and on the day of evaluation, he also had a repeat MRI brain as well as MR spectroscopy. And the repeat MRI brain is showing clear new strokes involving bilateral basal ganglia. And there was a significantly elevated lactate peak here and very low N-acetyl aspartate peak. And taking into account of the metabolic labs as well as HPO, and in discussion with neurology and Dr. Calhoun, who's our metabolic expert, we gave Sutton a clinical diagnosis of Lee spectrum disorder. As a next step towards accurate molecular diagnosis, we have already initiated short-read whole genome sequencing on blood and skin for Sutton. We have completed long-read genome sequencing for Sutton, including the mitochondrial genome. We have performed a skin biopsy, and currently we are trying to grow his skin fibroblast for downstream assays. We are planning to do mitochondrial DNA sequencing on urine sample, and his metabolomics is in process. All these testing is only possible because of research-based component of UDP. At this stage, we don't have a diagnosis for him, but we won't stop looking for an answer for Sutton. Now we will move on to the second story. This is the story of Lydia, who's a 16-year-old girl who was reviewed at our UDP clinic for a complex infantile onset neurodevelopmental disorder, which started with motor delays, hypotonia, macrocephaly in infancy, progressed to involve her neuromuscular status. She became wheelchair bound by 4 years of age. At 14, she underwent exome sequencing, which returned with a VUS in SLC39A8 gene. And her mitochondrial DNA testing was negative. At around 14 years of age, she had a new phenotype of head tremors. At 16 years of age, as a part of the UDP evaluation, we did a repeat brain MRI, which showed moderate cerebellar hypoplasia, as you can see here in the sagittal section, predominantly involving the vermis. We then did short read whole genome sequencing, which returned with a VUS in NLGN2, and it again showed the same VUS in SLC39A8 gene. Long read sequencing did not identify additional pathogenic variants, and also there was no pathogenic variant identified on the alternate allele for SLC39A8. Metabolomics did show mildly deranged lipid metabolites. Based on these findings and the brain imaging, we wanted to repeat the CDG assay. And this time around, it was positive with indeterminate positive result. Then subsequently, we decided to do transcriptomics analysis to see what exactly is happening in terms of SLC39A8 gene expression. And clearly, there was significantly reduced counts and abnormal splicing events for SLC39A8 gene compared to control. Given that SLC39A8 is a manganese transporter in brain, and manganese is important for various biologic processes, we tested her manganese level, and it was very low. And we started to replenish her manganese by giving her manganese sulfate. And following replenishment, we could see a clear improvement in her CDG assay, which has normalized since then. Most importantly, she had improvement in some of her symptoms, especially the head tremors, as well as her behavioral manifestation. Now we'll switch gear, and we are going to hear from our patient's caregivers, as well as Anna Paulson, who's our UDP genetic counselor on undiagnosed diseases. This is Sutton's mom talking to us.
My name's Brooke Cruz. I'm Sutton's mom. I had a completely normal pregnancy with him. I did everything correctly. He had a completely normal birth. All his newborn screening was negative. He was such a healthy boy and happy boy up until like 3 months old, and that's when kind of viral infection hit him. I'm not going to get into the nitty-gritty like details, just the way that we've had to, yeah, you need to advocate for your kids, but the way we've had to overly advocate, because no one suspects something like this in kids. In the ER this last time, my 5-month-old son, went into respiratory failure and had multiple seizures back to back and lost control of his eye movement. I mean, it's kind of back now. He's building that back, which is fantastic, but seeing him lose that so acutely was really scary, and not knowing what's wrong with him, and the way we stump the doctors here, or he stumps the doctors here, no one knows what to do with him, and it's really scary to watch him. How there's no more research or testing clinically that we can do, and as of 2025 for him, is terrifying. I'm grateful that Dr. Chandra is able to take these different like a skin biopsy and take his blood and analyze that and see what he can do for him. But the fact that he has something, a mitochondrial disorder that no one has ever diagnosed, is terrifying, and I just wanted to bring awareness to that. And no one should have to go through this. No parent should have to go through this. We weren't prepared for anything like this. I don't even have words. But all we can do is sit and pray for him and hope the best for him and be optimistic for him.
And this is a perspective from Lydia's
Hi, my
mom.
name's Carrie Wagner, and my daughter utilizes the undiagnosed clinic in Iowa City. It has been a tremendous help and has turned my daughter's life around since we've been going to the undiagnosed clinic, and she was discovered to have a nano-rare genetic disorder. Prior to this, the schools, doctors, family, everybody just assumed that my daughter's outbursts were because of the way I was parenting her. So they treated it as such. It wasn't until she was diagnosed and we found out why she was having these outbursts that people realized that it wasn't just bad parenting, it was something else. And now we've slowed down the progression of the brain atrophy, and it's made a world of difference. The undiagnosed clinic is so helpful in finding her diagnosis, and it is needed for other children as well to help them and their families to get diagnoses.
And this is the perspective reflection from Anna Paulson, who is our UDP genetic counselor.
My name is Anna, and I'm the genetic counselor who's part of the Iowa Undiagnosed Disease Program. In the roughly 2 years since we started enrolling families into our program, a few key themes have emerged related to access and care. In our Iowa Undiagnosed Disease Program, our patients have complex medical and developmental concerns, where the majority of the families we see receive their medical care through governmental support. Most of our families would not have the means or the ability to travel to other UDN sites for an evaluation and continued care. We have the ability to see these patients back on a more regular basis for follow-up evaluations and other visits as needed because we're in their home state or they live in a state that's surrounding Iowa. We're able to take care of the coordination of their care if a new concern arises and place referrals, because this is the site that they receive most of their care. And we're also able to connect families to local resources based on their current needs. And also the Iowa Undiagnosed Disease Program steps in where insurance stops. We don't have the ability to do additional genetic testing that insurance won't cover. We have research abilities to do further. And finally, I'll go the extra mile for my patients with rare diseases because they matter and their families matter. And we can put the focus for the families back on their family, and we'll take care of the science.
And just to conclude, accurate diagnosis is the most important milestone in a rare disease patient's journey. And sometimes the diagnostic odyssey is just due to lack of knowledge about the condition. And close partnership with different stakeholders is really important. We know medicine is evolving, and whatever is rare today won't be rare tomorrow. And we must keep looking for an answer. And UDP model is going to be the standard of care in the future. So to conclude, it is definitely worth going the extra mile, no matter how long it takes to reach an accurate diagnosis. I would like to thank all these people who have supported this program, especially all our UDP patients and their families. The program wouldn't have been possible without the generous donation from the kind-hearted philanthropic donors. And lastly, I would like to dedicate this talk to Meg Young, who unfortunately lost her battle with a catastrophic undiagnosed rare disease last year.
Thank you, Dr. Chandra, and please pass along our special appreciation for the parents and patients who generously shared their stories. And that was a tough nut to crack there. Those were really sweet stories. Thank you for sharing. As a reminder, we are holding all questions until the end, and please put your questions in the Q&A. Use your chat to converse with each other. Now, please let me introduce Dr. Mustafa Tikan, who will, among many roles, is the director of the University of Miami NORD Rare Disease Centers of Excellence. Dr. Tikan will introduce the next two presenters.
Thank you, Mary Beth. I'm very pleased to introduce our speakers today from University of Miami. And we are pretty grateful for the NORD for giving us this opportunity to share our experience in rare and undiagnosed diseases. We are, like you said, our NORD Center of Excellence for Rare Disease, also a clinical site of an NIH Undiagnosed Diseases Network. And as part of these programs, we have seen and evaluated several hundred children and adults with undiagnosed diseases throughout Florida. And increasing access to our programs have always been a top priority for us. Today, it's my pleasure to introduce two prominent speakers from our side who are leading our efforts to increase access. The first is Dr. Nicholas Borja. He's a clinical geneticist and assistant professor at our Department of Human Genetics. He's dedicated to advancing rare disease diagnostics and expanding genetic evaluation services. And next speaker is Dr. Leshon Peart. She serves as our research coordinator on rare diseases, and she plays a vital role in developing community partnership and research initiatives that enhance participation in rare diseases. So Dr. Borja is going to take next. Thank you.
Thank you, Dr. Tikan, and thank you to NORD for allowing for us to speak today. We'll be sharing, Dr. Peart and I will be sharing on our efforts to improve access to rare disease research in Florida. And as Dr. Chandra discussed in his really affecting talk, the Undiagnosed Diseases Network and undiagnosed diseases programs across the country, they really focus on solving medical mysteries through team science. And I think that's such a succinct and beautiful way of putting kind of the dual roles of the UDN, insofar as we're really focused on improving outcomes for patients. The University of Miami joined the UDN actually in 2018 when the UDN was expanding to 12 clinical sites. And we serve all the patients in Florida who are interested in applying to the program. And our North Star, our number one goal, is to shorten the diagnostic odyssey by providing specialized evaluations and comprehensive genetic testing. And it's really amazing the scale that the UDN has been able to operate at. We've received over 7,689 applicants with 2,740 participants, and 31.2% of those have received a diagnosis to date. So a total of 855 patients who were otherwise undiagnosed were able to receive a diagnosis through the program. And the twin pillar of our efforts to shorten the diagnostic odyssey for our patients is really to understand and advance research in undiagnosed diseases. So I think, it's a mission that's central to NORD as well. And our clinical site is really proud of the work that we've been able to do to characterize novel variants and novel phenotypes. And we've also engaged in collaboration with other groups across the world that has led to gene discovery. So I think that's the team science element of this. And I think that's our secret sauce, both in the UDN and in NORD. Collaborations are really what allow us to go from not really being able to fully understand a condition that is nano rare to being able to not only understand the condition, but diagnose more patients. So here's just an example of some of the publications that we've been able to drive forward over the past couple of years. And I think the insight that I think is really at the core of all the work that we've been doing is that the key ingredient is really our patients. They are not just the source of our mission, but our patients are what motivate us to move this science forward. So Leshon and our whole clinical group have been working really hard to figure out how to bring the patients that need the UDN in. How do we make sure that it's a resource that is used by those who need it most? And so I want to give her the floor now to talk about all the efforts that she's been spearheading to broadening access at the University of Miami clinical site. So thank you. Leshon, you're on mute, I think.
Sorry. So just going into, you can hear me now, correct?
Yes.
Okay.
Yes.
So just how we're increasing access at the University of Miami through the UDN program is we have tried to partner with our local hospitals around. So one of the major ones that we have in our neighborhood, it's Jackson Memorial Hospital, which is the largest teaching hospital here in the South Florida area. And we also partner with the Bruce W. Carter Veteran Medical Center that serves around 150 veterans. And they also run several satellite clinics. And of course, outside of those neighboring partnerships we have 30 outpatient University of Miami centers. And probably like most of our health systems, this reaches extending further and further each year. So we definitely are trying to make sure that we partner with our hospitals around us to make sure that we could increase this access of the Undiagnosed Diseases Network to those that have rare diseases. So outside of just partnering with our local hospitals, we have made a network within our University of Miami clinics. So we paired with a number of specialists from multidisciplinary clinics at the University of Miami to ask them to come on board to the University Miami site's UDN program to be co-investigators. So we have them invested where they're able to refer their own patients at their clinics that have a rare disease to the Undiagnosed Disease Network. And also they're able to be a part of the diagnosis process where they could be a part of the meetings where we go over results and we discuss what's found and management. So we discussed how we're increasing access through our local hospitals, through our internal specialty clinics here, and we wanted to increase that access even more into our community. So we created at the University of Miami a community advisory board, and this has a number of organizations that serve the community where we get together and we discuss how can we work together to help reach a greater awareness and engage throughout Florida. So we have the Health Choice Network that we partnered with. They are a community hospital network. We have brought in a UDN parent liaison where this is an actual parent of a participant in the UDN. So we're getting her voice from the parents' perspective on how we could share this information to the community. And we've partnered with nonprofit health and social service organization, Center for Haitian Studies, and also Best Buddies, which is a program helping people with intellectual disabilities and developmental delays. What has birthed through these meetings that we have every other month are certain outreach programs and social support programs. So with our partnership with Best Buddies, they were able to partner us with their sister organization, Unis Buddies, and they are a social support program for patients with unique rare diseases that are specifically in the area of intellectual disabilities and developmental delays, where they pair them with a mentor that could help them know about the resources that are available to them. With our partnership with Best Buddies, also, they were able to share with us some outreach opportunities that could be a part of to help share the information about the Undiagnosed Disease Network. And this coming up April, actually, we're going to be participating in the Best Buddies Friendship Walk, where we will sponsor a table and we'll be able to share information with the community about Undiagnosed Disease Network, so we could let those that have a rare disease know about the resources that are available to them at the University of Miami through the UDM. And this is just a quick snapshot of some of the faces that are a part of the community partnerships that we are working with. So discussing roles and responsibilities. So as you can see, as we paired up with the community and the university, we all have our own roles and responsibilities on how we can increase this access to the rare disease community around us. So from the University of Miami perspective, our role is we want to engage in the communities, in the community to share this information. Once they are enrolled into the research program, we're conducting clinical evaluations, and we do help to decrease the travel burden through providing telemedicine visits, and we will try our best to do remote sampling when we can. So after doing like your basic blood or saliva samples, and if we're able to find something through genetic testing, we'll go over the results, we'll share that information with the providers and the family. But if something is still not found, we'll go a little further in the research, and we'll offer further testing such as metabolomics or functional studies, or even move them to animal models. So the roles and responsibilities of our community partners is they help to support enrollment through the federally qualified health centers. So they're able to share the information in those different local community hospitals. They also coordinate with the community health providers on training. So we're helping to train the providers of these community health centers on how to identify rare diseases and how to be able to let them know about the resources there are available around them if they are on this odyssey where they're still undiagnosed. So it's very important to make sure we have a communication protocol set, since we have so many groups. We have our community ambassador board, we have our community partners, we have our parents, we have our providers. So to make sure we're all on the same page, working together to increase access to our rare disease patients, is we want to make sure that we're all communicating effectively and in an organized manner. So we have monthly community partnership meetings. We have our ambassador community, our community ambassador board meeting every 2 months. And we do host some annual virtual meeting with the PIs and the community collaborators. And we also have an in-person one, an annual in-person one between the PI and our community partner as well. So we want to make sure that we keep the access going. So we don't want it to die off. We want to make sure that we're setting things in order so that this continues to roll in and reach the community around us that have rare disease. So we are, as I mentioned before, we're offering training to our community partner providers on undiagnosed rare disease cases. They're invited to join our meetings where we discuss these cases and the management. We're offering the genetic testing resources, and we're offering community-driven resources for long-term sustainability through our support groups and social support groups, as I mentioned, through certain programs like Uni's Buddies and Best Buddies programs. So this is just it's not inclusive of everyone that we serve, but this is a lot of the areas in Florida that we serve right now. So all of the stars are patients that we actually have recruited and are part of the Undiagnosed Diseases Network at the University of Miami. So we do serve all of Florida. And I know I discussed the Undiagnosed Diseases Network a lot because that is our larger bucket where our rare disease patients will be best served. But outside of the Undiagnosed Diseases Network at Miami, we do have other research opportunities for rare disease patients at So all of our patients referred to our genetics department are pre-screened for research opportunities. So we share available longitudinal studies and clinical trials available for enrollment under a number of studies. So to name a few, we have a hearing loss study, eye disease study, geophilic dysplasia study, brain anomalies, and ASO therapy trial study. So we do try to make sure we share this information to all who are applicable. And that is it. I thank you so much for your time. And I thank you for this. And I understand we're going to do questions after, so I'll just stop sharing here.
Excellent. Thank you very much. Thank you, Dr. Teakin, Dr. Borja, whose name I've been pronouncing, I now know for about mispronouncing 3 years. Sorry about that. Please correct me in the future. And Dr. Peart. As a reminder, we are holding all questions to the end, but please put your questions in the Q&A. So the directors of UCLA NORD Center of Excellence, Dr. Stanley Nelson, Dr. Julian Martinez, and Dr. Nicola Longo were unable to join us for the event, so I have the pleasure of introducing our last presenter of the event, Dr. Bianca Russel. Dr. Russel is a geneticist with UCLA Health System whose practice is located in the rural central coast of California. Dr. Russel is the only geneticist covering a large region from Los Angeles to San Francisco Bay Area, taking care of patients with limited access to subspecialty and complex care. This talk will focus on the challenges and successes of providing genetic care for indigenous and rural communities on the central coast of California and how UCLA is working to provide more equitable access to care through community clinics. Thank you, Dr. Russel.
Great. Thank you so much, Mary Beth, for that introduction. It's a privilege and an honor to be here. And I'm really excited to share this story. It's really been a journey to provide rare care for the community here on the central coast of California. I grew up in this community in San Luis Obispo, which we'll talk next about some of the geography of the area. But I started my career at UCLA in Los Angeles. But I quickly learned that about a fourth of our patients we cared for in Los Angeles were traveling between 2 and 4 hours from the Central Coast to receive their genetics care. And these patients tended to be the most vulnerable within our healthcare system. They struggled most with access to care, language barriers, and challenges navigating the health system. So in 2021, I proposed that we develop a local UCLA genetics practice that would help support these families in their own home community. And since then, we've been working hard to build a community practice here. We are the most northern of the UCLA community sites. And my group here is made up of myself as well as a genetic counselor, social worker, bilingual Spanish-speaking administrators, and a metabolic team that covers our clinic remotely. So we'll start by a little bit of geography here for those that aren't familiar. So this is a map of California. The Tri-Counties region, or the Central Coast, is made up of 3 counties, Ventura being the southernmost county, and Santa Barbara and San Luis Obispo being on the northern side. Overall, the population is about 1.6 million, and we do have some surrounding areas, including Monterey and to the north, and Fresno to the east, that also contribute to the demographics for the region. In general, medical care in the region includes several healthcare systems with regional hospitals, as well as community health clinics and private practices. Specialty pediatrics care is very limited and is mostly localized to Santa Barbara, but many of our patients endure long wait times and limited access due to a high demand and limited providers. There are only 16 pediatric ICU beds in the Tri-Counties region, along with just under 80 neonatal ICU beds. Many of our families therefore have to travel long distances to Los Angeles, Fresno, or the Bay Area for many of their basic care needs, and certainly for most of their complex care needs. These are some pictures taken from our travel agencies, so reasons to come and visit us here. But the region itself is beautiful and is known for its natural beauty, outdoor adventuring, tourism, the wine industry, and livestock and agricultural production. The Central Coast is a top producer in the state and in the country for wine grapes, strawberries, avocados, and livestock. And the majority of the labor force is made up of Mexican migrants located in Santa Maria, Paso Robles, Ventura, and Oxnard. And according to the 2023 census, nearly 40% of the population across our region is of Hispanic or Latino descent. Within that Latino population, the most vulnerable individuals are within the indigenous Mixtecan community. This is really a beautiful community of families from the southern regions of Mexico, primarily from the Mexican states of Oaxaca, Guerrero, Michoacan, and Puebla. And according to one of our big support organizations in the community called Mixteco Indigena Community Organization Project, or MECOP, the population in our region here is about 50 to 60,000 people. And they're predicted that in the state of California, there are around 350,000 individuals from this community. And since the 1970s, families have been migrating to this region due to loss of agricultural viability and severe soil erosion in their home communities. And there are, in fact, over 50 Mixtecan dialects, with the most common dialect on the Central Coast being Mixteco Bajo and Mixteco Alto. So these are languages that are quite distinct from Spanish, and the Mixtec languages are commonly considered a tonal language, and there is no written form of the languages that is used amongst the community. So as you can imagine, this results in some significant challenges related to communication, though some of our families do speak some basic Spanish. The Mixtecan community also has its own unique cultural practices that differ from some of the other Latino cultures in the area. From a genetics perspective, families have lived in isolated regions of Mexico for many generations with limited mixing outside their communities. And this has resulted in increased carrier frequency for rare genetic conditions that are not commonly reported in other populations. This results in a very unique set of challenges related to counseling these families on genetic risks and for caring for individuals with ultra rare and often severe genetic conditions. So I want to take you through just a few of the conditions we see more commonly here on the Central Coast and then in other regions in the country and in the world. So cobalamin C deficiency is a rare autosomal recessive metabolic condition. It's caused by an enzymatic defect in cobalamin, also known as B12 metabolism. It's identified on our state newborn screening program and treated primarily with a daily high-dose injection of B12 that's required for life. And these injections can be challenging to attain for our families. In the state of California, there is only one pharmacy that can produce the high concentration injectable form that we need, and they ship that to our families directly. And it's hard for families to learn how to administer a daily injection for their children. But if they're successful at continuing this treatment, the treatment does prevent progressive neurologic decline, seizures, and many other life-threatening complications seen in those that are untreated. Interestingly, within the local Hispanic community here, we have multiple founder variants that increase the frequency of this condition. So on a national level, it occurs in 1 in 200,000 births in the US, but in our community, the rate here is 1 out of every 46,000 births. And so many of these individuals actually have a milder form of the condition than what we see on a national level. And so our families do very, very well as long as they're able to have the support that they need and the access to medications to treat with those B12 injections that they begin soon after birth. Another condition we see here with higher frequency is called Zellweger spectrum disorder. This is a rare autosomal recessive progressive neurodegenerative disorder with multi-organ involvement. And it's due to defects in peroxisome biogenesis. It's caused by variants in 1 of 13 different PEX genes. There's a very large clinical spectrum that we can see And many individuals with Zellweger do survive into adulthood, but in our community, there's a common PEC6 variant that we haven't seen outside of the Mestekin community. And this variant results in a severe form of the disease with early lethality. Incidentally, the California newborn screen will identify this condition in many individuals, and it comes through as a false positive for X-linked adrenal leukodystrophy. So these patients are being picked up just a few days after birth. Unfortunately, treatment options are quite limited in the severe form of the disease. But what we've found here is that early diagnosis and being able to make these connections with the genotype, phenotype, and understanding what their specific variant looks like in this community has allowed families to have a much shortened diagnostic odyssey and helped limit unnecessary interventions and help families increase critical time with their loved ones at home outside of the hospital. And one of the things that this has really brought us to realize is that the increased carrier frequency of PEC6 in our Mestekin community, it really deserves a program to help understand how we can counsel families and support them through this process. So a collaborative effort with some amazing colleagues of mine at Valley Children's Hospital in the Central Valley of California, where they also serve a large Mestekin community. There are some really exciting efforts to increase carrier screening for this specific PEC6 variant that is really critical to this community. And our hope is that the more inclusive our carrier testing can be of Indigenous communities will allow families to help be better informed and have more control over their reproductive process. So when we look at what are some of the barriers for this community, there are three major categories. And the first is transportation. So our families often struggle with the cost of transportation, the time required that's missing work, their agricultural jobs. If they don't work, they don't get paid. So it can have a dramatic impact on the household. It's also a challenge often to have safe access to a car seat, and a driver that's safe who has a valid driver's license. And one of their big challenges is if the other children cannot come to the visit, it can be very difficult for families to find childcare during medical visits. The second is also the cost of healthcare and health insurance in general. Missing work, as I've mentioned, is a big factor for our families, and uncovered medical expenses, things like shipping, for example, for medications that insurance doesn't cover, can really have a dramatic impact for these families. And often children are able to attain our state medical insurance, but parents may not be for immigration reasons or other complexities within the healthcare system. And then the third major barrier is language. So having access to appropriate interpreters is really a challenge in the Mestekin dialects. As you can imagine, it's tricky to identify which dialects the families are speaking and then have access to the appropriate interpreters for their visits. Those Spanish interpreters are readily available. It can be very difficult to communicate with our Mestekin families in Spanish when they understand very little bit of Spanish to begin with. Another challenge is overall healthcare literacy. Many of our families have not had formal education, and if they have, even still, their language doesn't include many words for some of the medical practices that we are discussing with them. So it can be very difficult to communicate on that level. And of course, our health system is quite complicated and a challenge for many of our families. So what are we doing here at UCLA in the San Luis Obispo or SLO Genetics Clinic to help? One of my big goals is keeping it local. So our clinic location is within 30 to 60 minutes for many of our families, primarily out of the Santa Maria area. We often will help our families get medical transport through their insurance, which is a process that many of them don't know how to navigate but have access to. Our clinic is located in an area where there's not any traffic and the parking is free, which is a big difference from our clinics in the Los Angeles area and really is a barrier that our families benefit from not having. We also work really closely within the academic centers for our referral network. So if I need to send a patient to Los Angeles to see a specialist, will communicate with that specialist, help coordinate those visits. Oftentimes, if they need to use our clinic for telemedicine because they don't have access to those things at home, they can come to the clinic for that. And also help coordinating the follow-up. So many times specialists will recommend labs, imaging, and follow-up that we can execute locally and ensure that those things get translated to the electronic medical record system. One of our big changes that has had a dramatic impact is to do cheek swabs or buccal samples in the clinic during their visits. And that has really increased compliance with testing and accessibility so that they don't have to coordinate things at home or come back for a second visit. And we do UDN and research sample collection locally in the clinic, which has really increased engagement in research within this community. Another thing we work on is being flexible. So we have no policy on missed appointments. In fact, if a patient is missing appointments, it triggers us to look further into why that's happening and try and figure out how we can help. And occasionally we do visits outside of typical hours to help those families that are most in need and have more limitations in their availability. And we work really hard to be a resource. So we have an amazing social worker who helps support our clinic. And we do a lot of referring to local community programs and food banks. We think outside of the box, not just about their medical needs, but the needs of the whole family. And we have internal funding that helps support unmet medical needs. For example, shipping costs for some of the medications that our families wouldn't otherwise have covered. And we keep trying. So a lot of what we do in our clinic is managing care. So many of our patients will have a genetic diagnosis and they will need follow-up with their multiple specialists. They'll need lab work. They'll need help getting support in school. And we'll follow them more frequently to help make sure that they're staying on track and they're getting access to the resources that they deserve. And we attempt to understand what the barriers and challenges are and help reduce those for our families. And we got to adjust how we communicate. So communication is certainly a challenge. When I counsel families, we use lots of pictures, simple words, and repetition. We see them multiple times and we talk about the same thing in a slightly different way. And we help make sure that the families really do understand some of the complex genetic processes and diagnoses. When able, we'll use telemedicine and phone calls. Many of our families have limitations in their ability to do telemedicine, so we'll use phone calls to help them limit missed work and help accommodate their specific needs. And we're really excited to be trying some alternative forms of communication in collaboration with a fantastic genetic counseling student at Boise State, Alina Prager. She developed this video in Mixteco Bajo, which is one of the more common dialects for our region, that goes through autosomal recessive inheritance and some basic genetic concepts. So this was just completed. We're excited to try it out with our families, but really looking forward to having some educational materials that are in their native language. So in conclusion, providing rare disease care for rural underserved communities is really complicated. It requires local insight into the community specific challenges. And I hope I can have showed you today that the unique populations really do have a different prevalence of rare disease with genotype phenotype correlations that impact treatment and counseling. Caring for these vulnerable populations is really critical to providing more equitable access to care. And it's just an absolute pleasure to be able to share this story with you and hope some inspiration as well. So I think that brings us to the end here, and I want to pass it off for some questions.
Thank you so much, Dr. Russell. We have 2 minutes left, so I think we have time for maybe one question, one person to answer the question. So, and for those of you that submitted questions, we will circulate them to panelists and follow up with you separately. So the one question I think we can get to is, this person is anonymous, and they said, my child's rare disease is primarily treated via surgical interventions, but it impacts their whole person. Do you have any tips for engaging providers to look at rare diseases in a more multidisciplinary way? And I don't know who would like to take that. I think any of our panelists today can speak to that. Don't everybody jump at once.
I mean, I I think one of the best ways is to ask them about programs. I mean, to find a multidisciplinary like approach, it's gonna probably be a part of some program, like where you have a lot of providers working together, research program. So to just ask, and even there's a lot of patients that will find out about different undiagnosed disease programs or rare disease programs through Facebook groups. I've seen that as well. So even just looking at groups specific to symptoms, or researching or asking your provider if they know about any research programs at their site or around. I think that's probably one of the best things that you can do if you're looking for something that has a wide range of different providers and different specialties working together.
Yeah, I think along those lines, if you can find a provider that will really be your champion, help you put the pieces together, that makes a big difference. Whether that's a geneticist, a primary care provider, you know, a neurologist, whoever is sort of at the center of it, if you can find someone that will really help support more than just the one piece, but the bigger picture, that can make a big difference. And many healthcare systems do have specialists now that specialize in complex care management. So looking into those types of programs may be helpful.
Thank you so much, Dr. Peart and Dr. Russell. Really appreciate your answers to that question. And more questions are coming in, so I apologize to everybody, but we will certainly circulate these questions to the panelists. And thank you all so much for being here, attending our first NORD Rare Disease Centers of Excellence Rare Disease Day Grand Rounds. Hope to bring this programming back again next year to kick off Rare Disease Day celebration. And I encourage all of you to head to rarediseaseday.org to learn how you can get involved for the remainder of February as we get closer and closer to the 28th. And again, really, thank you for your time to all of our panelists from Iowa, Miami, UCLA. With that, I think we will end the meeting, and you can keep an eye out for the recording and a follow-up email. Take care, everybody. Thank you.
Thank you, everyone. Bye-bye.